Everybody, welcome back to the You're Not Broken podcast. I have good friends. I'm going to say they're new good friends, but we have Dr. Abraham Morgentaler and Dr. Marianne Brandon joining us today. It's not your first times, but it's your first times together.
This is true.
And that's worth it right there.
That's worth it right there. You guys are the dynamic duo behind the Sex Doctors podcast, which is a new podcast. Newish, yeah. How long has it been out? See, it's new. That's new in the podcast world. But the average podcaster doesn't get more than like 7 episodes in. So you're already like ahead of the people who get a good idea. Yeah, 7 episodes is like what a podcast will make before they stop. Because it sounds like a really good idea. And then people are like, oh, it's actually work. And you're like, yeah, it's work. It's a lot of work. But I love your podcast. I'm obsessed with it. I follow all of them. I love that they're short. I love that there's a cat involved. I love that you guys are flirty with each other. And it's like super playful. And like you bring good hard science into easily explainable, like tactical, what do you do with this plans.
Well, thank you so much. It's very much an honor to hear you say that.
You guys are going to have dinner tonight and be like, oh, somebody likes our podcast.
Well, at least now we know that one person is listening.
You're like, don't forget to go leave a 5-star review, Kelly.
I know.
It's one. It'll be you. That's how my podcast started out, though. Like my mom listened for 6 months. And then you just get better and better and better. And you find your voice and you find, but I think you guys are nailing it out of the gate. It's just putting in the reps at this point.
Well, thank you so much. And it's great to be with you. Again.
So for people who want to go back, previous episodes with Dr. Morgentaler was 257. The title of that podcast episode is Testosterone. I like to keep things simple for people. And then Dr. Brandon was episode 242, Modern Sex Challenges, still applicable, even though probably 242 is about 100 episodes ago. So that's probably about 2 years ago that we did that.
Wow,
you're rolling.
Time flies.
It does.
I know. Yeah, exactly. We're just getting, I mean, people look at Joe Rogan and they're like, you realize he podcasted for like 10 years before he got his big podcast deal. Like people don't see like the work that goes into like the overnight success. So just got to keep going. But you guys aren't an overnight success. You've been doing your craft for quite a while.
True enough.
Yeah.
Dr. Morgentaler, you were doing your craft like back in the day when testosterone caused prostate cancer, so long ago.
I fell off my dinosaur to do some of that.
Well, yeah, because you were around in the time of lizards. Because that's what your recent TEDx was about.
Started with the lizards. They are like little miniature dinosaurs. Yeah. So, my story, what I like about my story is that it was the beginning of what I think is really in many ways the modern era of urology and also the modern era of testosterone. There was not, when I was in my training, nobody got testosterone. Everybody thought it caused prostate cancer. This is crazy. I was taught, all the residents were taught that if a man got an injection of testosterone today, he'd be back in a normal guy, healthy. He'd be back within a month with an aggressive prostate cancer.
Then that was dogma, not rooted in meta-analyses.
Not rooted in anything. And it's actually amazing how that came about. It's sort of like a case of broken telephone, right?
Yeah.
There were 2 things. One is that Charles Huggins, who was awarded the Nobel Prize,
who was a urologist. Urologist like our one Nobel Prize winner, or maybe we have 2.
There's a second one named Forsman, but who became a urologist.
After his Nobel Prize?
But what he got the Nobel Prize for was he stuck a wire in his veins and he got it to his heart. And he went to X-ray and he took an X-ray and showed that the wire could connect. And it became the mechanism for people doing cardiac catheterization.
That's a big deal.
But
apparently Swan-Ganz for the Swan-Ganz catheter was on a sailboat when he got the inspiration for the Swan-Ganz catheter and how they could get it to like sail through to get to the heart.
Yeah.
I know.
So
okay, so we have a Nobel Prize winner in urology. Therefore, we respected that as dogma, and we didn't question the fact that testosterone causes prostate cancer.
So there were 2 things. So Huggins wrote in 1941 that if you gave testosterone, that it made metastatic prostate cancer worse. He looked only in guys with metastatic cancer. And he based that on acid phosphatase results. We don't use acid phosphatase anymore because it's not very good. Once PSA came in, we got rid of acid phosphatase. It bounces all over. And it turned out amazingly that it was based on just one patient. was not yet castrated. It's an unbelievable story, followed for only 18 days. And then the second piece of information that people confused and put together was that there was another paper that came out in 1981, I think it was, by Fowler and Whitmore. And that was a group of a set of studies from Memorial Sloan Kettering. And they had all these different protocols, and they looked at everybody that got testosterone who had metastatic cancer. And because they had different protocols and different ways of measuring, they said, let's just use the term an unfavorable response, which could be a whole variety of things, including a rise in acid phosphatase because PSA wasn't around yet. It could be pain. It could be anything like that. And they looked at men who also had been almost all of them castrated already. And they said at 1 month, what percent of these guys have something bad? And it was a high percentage. It was 45 out of 52 guys. But those were guys with metastatic cancer. Now, as an aside, and your audience may appreciate this, is that all but 4 of those 52 men had already been castrated. There were only 4 guys who were not yet castrated. And when they got
And back then, they surgically removed testicles. There was not
Yeah.
a medication. There's not medical castration. This is we removed your testicles.
Right.
Yep.
And I did that at the beginning of my career too. We didn't have the medicines like Lupron. Anyway, of the 4 guys who were hormonally okay, intact, still had their testicles, 3 of them got testosterone for very long periods of time. Nothing happened to them. This is men with metastatic cancer. But so what people did is they put together this mishmash. Both of them were thought to be true. One was Huggins said testosterone makes metastatic cancer worse. The other one said within 1 month, unfavorable response. But of course, they were all castrated. So if we give testosterone to a normal guy, he'll get prostate cancer, which was never checked in any of them.
That's a leap when
and
you look
it'll
at it
be
that way.
aggressive cancer, and it'll happen in 1 month. But that's how everything, when we are so afraid of testosterone, that's how it all went.
And now, so when I was in training, we wouldn't give testosterone to a treated or cured man with prostate cancer. And now we're informed consent for everybody, risk benefits, blah, blah, blah. But now we will consider testosterone replacement if your testosterone's low in men who are on active surveillance, meaning low grade, low risk. Risk of treating will cause more side effects than risk of, keeping it there. But if you have low testosterone, we're going to replete it because it's low and you're symptomatic. So we've come a long way with testosterone and prostate cancer.
Such a long way.
And I always take it to breast cancer because the quality of life in these women is some of the worst, most poorly treated quality of life in medicine, probably. And I'm like, listen, we can change things. We can relook at the data. And the same thing with breast cancer. There's same with you saying there's 4 patients. In breast cancer, there's literally 23 patients on which we have actual data. And that's why we say women can't be on hormones post-breast cancer. So I always use the prostate cancer testosterone as things change. We can reanalyze data. We can do more studies. We can consider risks and benefits and quality of life. Because I think so many people think medicine is set in stone, and it's not set in stone. It is moving and evolving, and we're always learning.
Right. Sometimes more slowly than we'd like.
Well, there's that JAMA article that takes 17 years for good, air quote, good data to get from the research paper into clinical practice.
Yeah.
So,
but let's talk about
slow.
changing medicine for a second. So Dr. Kelly Casperson
Yes,
was
yes,
at
sir.
the FDA.
I was just at the FDA.
Very recent. I know, I'm talking about you actually.
Oh, yes. Yeah, I was there too. Yeah. No, it was very trippy to get to the place where your name tag is on the seat and you're like, my name is at this seat because I'm the best person in the country to be talking about this.
And not just any seat. That's an important seat.
Yeah,
so when
it's
you're
an important seat.
able to speak to the people in power and educate
Who know
them.
less about this than you.
Yeah, isn't that amazing, right?
It's cool, right? They can't know everything about everything. And for them to say, let's bring in the people who study this and learn from them. I love that. I love that they did that.
Yeah. Yeah. Very good. So
And
you did
one of the things I asked for, because I'm like, when you have the chance to go to the moon, bring the party, is one of the things I asked for is when we get the female dose testosterone product, not if, but when. I don't want it FDA approved for low libido. It's not what men have it approved for, and they'll have insurance issues with that. And doctors can't talk about sex, right? So doctor judgment with that. Like, we can't have it FDA approved for low libido. And I want the DEA restriction off of it, because I can't make a woman a gold medalist pole vaulter by giving her physiologic female T doses. Thank you. And I think it's a much more realistic ask than just deregulating testosterone in general. Like, that's a big ask. And I think people are using testosterone nefariously in high doses, not in standard medical clinics. And I can't make that go away. But as far as DEA resources go, and I know DEA people have gone to physicians' houses for prescribing female dose testosterone. And I'm like, what a waste of resources, man. So you hear that and you're like, dude, this is not the best use of your time. Like, God, it's awful. It's awful, right? So I'm like, I asked for that. I said, when we get the female dose testosterone, I want a DEA exclusion on this. Then we'll fight the fight of should a male level testosterone be deregulated. Many people say yes. But for the female dose, I'm like, that's not a nefarious, performance enhancing drug at this point in those doses. And right after that talk, because Dr. Marty McCary didn't know these things, right? He went and had a DEA meeting. Like, the DEA meeting was scheduled right after that talk was given. So we'll see.
Yeah. Well, you did a phenomenal job. I listened to all of it. I missed the first 2 minutes or so, and then I listened to all of it. It was excellent.
Thank you. And for anybody who's interested, if you go on YouTube and the FDA's YouTube channel, you can watch the full 2 hours there. My 5-minute talk is on my YouTube channel for people to go back and see what the heck we're talking about. I want to go back, if we can, for a second, now that I have both of you here. How did you guys meet?
He was lecturing at one of my conferences, and I was like, my gosh.
You got the tingles?
I was like, I gotta connect with this guy. Yeah.
Awesome. So did you connect at the conference?
Well, I tried to get his attention, raise my hand.
There was this beautiful woman sitting in the front row, and she raised her hand to ask a question when I was done. It's an organization for sex therapists. What's it called? Was it STAR?
Yeah.
STAR?
Yeah. Which I hear they're excellent.
They are.
Conferences, yeah.
And it was an interesting conference because I'd written a book which had come out, which was what got me the invitation there. The book
What's the name of the book?
Why Men Fake It.
Nice.
In paperback, it's now out as The Truth About Men and Sex. And I take a very positive view of men, much more positive than they're described in our culture.
Good. Thank you for providing the counterpoint.
Because what
every argument needs a counterpoint.
Yeah, and what guys say behind closed doors is something that's very different from the stereotype of the 18-year-old or 19-year-old on spring break, right? So guys are trying hard to be good partners, good sexual partners, providers in a way in terms of sex. It may be misguided, but that's how they're thinking. And in this group where we met, there was a lot of anti-male sentiment.
Sure. It's trending right now.
Exactly right.
But
Wait, what year was this? Was this ahead of the trend?
It was a while ago.
Probably 10, 11, 12 years ago.
But this anti-male thing has been brewing for a while.
Yeah, it's been growing. Yeah.
But Dr. Brandon was there in the front row, and she seemed really quite supportive of my point of view. So we connected and chatted and exchanged numbers. And before anything romantic happened, we actually wrote a paper together.
I'm sure many romances have started over an academic paper.
That's how we met.
Awesome.
We were just laughing about this paper that we were writing, and I had written up, an outline and filled it in based on what we had discussed. And as is typically the case for him, when he sees like someone's outline for a paper or a lecture, whatever, / yeah,
it's the best part. Editing.
He destroyed it, and then
it's called killing the babies. I gotta kill all the babies. Okay. That's a horrible term. I'm sorry for any offensive, but it's like you got to kill things that people love, basically, is what
that's what happened.
Yeah.
That's right. And then he wrote in his little chicken scratch, like what should be said in the document. And I couldn't even read his writing. So I'm trying really hard to decipher. And he asked me, well, can you read my writing now? No, I actually still can't.
I have physician's handwriting. It's a syndrome.
Yeah. No, it's a genetic disorder, probably. Yeah. It cannot be cured.
Yeah.
No
I
matter how
thought
many
it
electronic medical records
it
there are,
used
it
to be a
cannot be cured.
requirement to enter medical schools. You used to have unintelligible writing.
Yeah, well, they probably don't screen for that anymore because it's all
No,
electronic.
now it's all
That's
now it's all
yeah, totally. So, what percentage of men fake orgasm?
that's hard to say. But they did studies in college kids, and the numbers were huge. It was like 20% plus of college males.
One time, though. The research I think you're referring to have faked at least one time.
At least once. Right.
Okay.
At least once. But it's a substantial number of men. And the curious thing is, why do men fake it? And they do it for the same reason women do. To kind of say, good job. Let's put an end to you did good. Let's put an end to the activities for tonight. Let's get some rest. But it was the key story in that book, at least one chapter in the book. And when it was a young man in his 20s who came to see me. And at that time, I didn't know that men could fake orgasms. I never heard of it. I'd been practicing sexual medicine for quite a number of years already. And the guy came in, and his story was that he couldn't actually have an orgasm with intercourse. So he was dating. And while he was dating, without being seriously involved with anybody, he felt like he was a stud. He could just keep going forever. And then when things were over, he would take care of himself. And then as things happened, he fell in love. And that was his undoing. Because then his girlfriend started feeling bad about herself.
Yeah.
That he wasn't able to
Which is
climax.
what women are wont to do. We're wont to make it mean something about ourselves, negatively usually.
Isn't that right?
Yeah. So he started faking his orgasm so that she would feel okay about herself.
Right. Fair.
Yeah.
So
Fair.
so what did you do?
Well,
Because we didn't have medications like Addie back then.
No, we didn't. And so I put on my psychology hat and my sexual medicine hat. And the question really was about what was it that got him excited, and how did he have his first ever orgasm,
Mm-hmm.
which happened to be when he was in France as I forget, 13-year-old or something like that. And the smells and the French perfume was something that he remembers and associates with that. And so he had his girlfriend. I had him get his girlfriend to start wearing some French perfume, and it worked for him.
Love that. This is a very challenging thing, I think, for the average doctor when you have a 10-minute patient visit. Like, you can't get to the French perfume part, right? Like, ever. And here we are being like, well, does he need more Viagra? Does he need less Viagra? Does he need to stop porn? Does he need therapy? Like, what does he need? But it's like, sometimes the answers are not one size fits all.
So, I often encourage physicians to have a sort of pre-selected group they work within, like a therapist and other folks, so that they don't feel so afraid of asking these questions, because they're not only do they not have the time, but they may not have even the information on how to approach a treatment. Yeah. So if they have a treatment team that they can rely on, it allows them to be more free, I think, in inquiring about these sorts of things.
And I think that's such a much better answer than the shit doctors actually say to people, which should be that could be like a picture book I would do someday, is like the shit doctors say to people.
That would be.
And it's really bad.
Yeah.
I just heard today, this is like earlier today, that a prominent cancer center on the East Coast is recommending cancer survivors use Crisco for sex.
Are you kidding?
No, I can't make this shit up. Like, this has to be real life to be so ridiculous. So I'm like, oh, there's really good data on like vaginal estrogen, especially even for cancer survivors. Like, we can actually treat the physiologic problem and keep the Crisco on the shelves.
Crisco's what, like lard, right?
Yeah, it's like kind of like a synthetic, like a shelf stable.
Yeah, I didn't even know that was still made.
Yeah, right. Like, it's not good for you. We don't even cook with it anymore. Do not put it on your vulva.
I can't imagine.
I know. So yeah, it's a much better answer. One of your recent podcasts was talking about low testosterone being a risk factor for prostate cancer. And I want to segue that into, do you think we should be screening men for low testosterone?
Listen, I think every man turns 30 or so should probably get a testosterone level.
Thank you.
30 and above.
Do they need to get it before 9 a.m.?
No.
Okay. But what if insurance won't let you have testosterone because you got your lab at 9-4?
Well, then maybe you need to get it to have insurance pay for it. But you don't need it for biological reasons. But you need a blood test, and I think testosterone is the single most important blood test a man can have. And what I
Love
mean
that.
by important is that it tells us so much about what's going on in the body, right? So that a low level of testosterone is predictive of all sorts of things that we care about, right? Like obesity, diabetes. There's evidence that
Dementia.
metabolic syndrome, mental health, dementia. I mean, it depends what age we're talking about, right? Fertility, sexual function. There's no other blood test that's like that, right? Like everybody gets a glucose. Okay, that's good for diabetes, right? CRP. Okay, that's good for inflammation, whatever may be doing it. You get a cholesterol. It's good for cholesterol. But testosterone is reflective. It's certainly in the man. There's less work with this in women, but certainly in the man of a whole host of medical conditions that are important to know about.
Yeah, I agree. I think it's I think it's ridiculous that nobody has put that forward as a screening guideline recommendation, or maybe they haven't. Just nobody's taking it up. But I'm like, we check a blood pressure. Medicare requires a blood pressure at every visit. Like, not everybody has high blood pressure, but we want to look for it, right? And especially the association with mental health. Like, we have a mental health crisis in this country, and low testosterone is associated with depression.
Right.
But it's a screening tool for depression, which we don't otherwise have a screening tool for depression besides a questionnaire.
Can I backtrack? Because this is, I think, interesting. Is I asked Abe fairly recently, well, why do you say it doesn't matter what time the testosterone level is drawn? Because everyone else says it absolutely matters. So I'm thinking, are you back in the dark ages? Like, why do you still say this? And he did some really interesting research himself on this issue. I thought maybe.
Yeah. So, the whole testosterone field is filled with what I call lore, Lore. It's like old wives' tales. That's not a very nice term, is it? Old
I
wives'
know.
tales?
We should say
No.
old medical student professor tales, because it kind of comes down from.
Yeah, I don't think I
that.
can use that term anymore. It's like so politically incorrect. But anyway, so lore, and one of them is about the time of day. So it turns out that for young men, young healthy men, which means non-obese, no medical issues, what's clear is they have a higher level of testosterone in the morning than in the late afternoon. Okay. And that stuff's been shown. And for older men, it's also true, higher in the morning, lower in the late afternoon or early evening. And then it rises again while we sleep. And people have said, okay, then, so you have to get it in the morning when the testosterone level is highest. So first of all, if you wanted to do an EKG to find out if somebody has heart disease, would you do it when they're lying quietly at rest? Or maybe you might have them exercise.
You want to catch it.
You want to catch
If they have it, you want to catch it.
Right. So if you do it in the morning when the levels are highest, you're going to have the lowest yield of finding something that might be consistent with what the clinical picture is. The second thing is that the studies that were done, and they're all very small studies because where they do the 24-hour testosterones, because it's hard to keep people in overnight, right? And measure their blood every hour or a few hours. So they're like done in like 14 people, 12 people. Those are the numbers they have. Those published studies that everybody says, oh, look at how amazing the diurnal variation is, highest in the morning, less at night. We're all in the super fit. They were only in the studies, no medications, non-obese, no medical issues. That's not who we see in our practices, right? So I did a study together with my group where we also kept people in over 24 hours and measured their testosterone I think it was 3 hours, every 3 or 4 hours, and over 24 hours. And it turned out that if your levels were low, below 300, there was no diurnal variation at all. If your levels were above, if you had a normal testosterone to begin with, there was diurnal variation, which we know, but not nearly as. Now, these were unselected people. I mean, like, we didn't care if they were on meds or not. Many of them were overweight. And so there was diurnal variation, but it was blunted. But a very important study, I was also involved with. David Crawford is the first author. This was from back in the day when we thought we were
Was it E. David Crawford?
Yeah, E. David Crawford, EDC.
I love E. David Crawford.
Yeah, we love E. David Crawford. So, and he's brilliant.
E. David Crawford listens. E. David Crawford, are you listening right now? If so, we love you.
Well, maybe we need to wake him up. Tell him he needs to listen. Yeah.
Exactly.
So he started what was called Prostate Cancer Awareness Week. Mm-hmm. So we thought we had this new blood test. We were going to cure the world of prostate cancer. And urologists around the country volunteered their time to open up their clinics. It was usually 1 week. We'd do a few evenings or something. Some people did in the day, and they got a blood test, and somebody paid, I think there was a grant to pay for PSA checking. David at some point became interested in testosterone and added testosterone to those blood tests. So what we had was 3,000 men, 3,001, I think, from all over the United States. We knew the time of day that their blood tests were being measured, and they all had to be older than 40, because it was really PSA screening, right, for prostate cancer. So in that group of men, unselected, except that they showed up for Prostate Cancer Awareness Week, free screening, the serum testosterone was no different between 6 a.m. and 10 a.m., 10 a.m. to 12 p.m., 12 p.m. to 2 p.m. It's just flat. From 2 p.m. to 6 p.m., that time slot, it went down a little bit by about 13%. So it's something. But what it really meant was that for our average guy that we're checking around a testosterone level on,
Your
let's say
average
40
American of the age that comes in with, hey, doc, I'm not feeling like myself.
between 6 a.m. and 2 p.m., there is not one minuscule difference in their average testosterone.
I love that. I love like that myth busting. We're very aligned.
And if you've got low
in that.
testosterone, the diurnal variation is off. You don't have it.
I love it. And if you have borderline low testosterone, why aren't we trying to catch it?
Right.
Right? Like if it happens to be 3:04, it's 3:04 at 8 a.m. They're like, you can't have testosterone because your testosterone's normal.
Yeah.
They're like,
Yeah.
check
Well,
it
there's some
later.
people who believe that.
I just had a provider reach out to me that she sent a woman to a lab, one of the big lab companies, and they refused to check her testosterone because she was female. I know. It's like, again, it'll go in my book of like the shit people say to women. And so the doctor called and called him on it of like, there's conditions in women where they have high testosterone and low testosterone and blah, 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 blah. And then they switched and they're like, oh, well, maybe it wasn't because she was a woman. Maybe it was because it was 10 a.m. And they kept moving the reason why they refused this person.
Yeah.
And I'm like, you guys, just check a effing testosterone. Like, you can stop overcomplicating all of this.
Yeah, it's not that complicated.
It's not that complicated. Right, yeah. Let's switch gears for a second and give us some help of when sex gets boring.
Oh, yeah.
What do we do?
I think that's more my wheelhouse. Yeah. So
Morgentaler's like, I've never been bored. Pass.
Yeah, we're going to leave the personal out of this. We're speaking purely professionally.
Purely your academic pursuits.
Purely professionally.
Oh, that's okay. So when sex gets boring, which happens for a whole lot of folks, instead of getting like, overreacting and saying, oh my God, like our sex life is over, it's boring, a couple of things. One is mindfulness is critical in this situation. So what you're going to see here when you open a magazine about this issue is they're going to say, try something new. That's not
okay. Buy a new piece of lingerie.
Right.
Which has probably solved zero people's problems long term.
Right.
But is great for the lingerie industry.
That's true. That's true. And the other problem is, generally, people have already tried something new and they've run out of things to try, right? Everybody has their sort of limit of what they're willing to do or what sounds interesting. So even if people are trying something new, they're done with the lingerie after a while and there's nothing else they want to try.
Yeah, they're like, this is itchy.
And you have to hand wash it.
Yeah.
Like,
I do not have time for the maintenance.
No.
Yeah.
Exactly. And here's where mindfulness comes in so helpful in that. So learning mindfulness meditation, particularly that kind of meditation, which you can easily do by getting an app. Not that it's easy. It's not easy, but you can easily get an app and start practicing. But what it teaches you is, your brain's going to like go in different places and think negative thoughts or whatever. That's what brains are designed to.
Right. It's not the flaw. It's the default software.
Exactly.
Yeah. Okay.
That's the software. So we can't expect it not to happen. And it happens at all times, including sex. But if you learn to focus on your body, like with mindfulness, you learn things like focusing on your breath in spite of what your brain's doing. If you bring that mindfulness to even the same activity you do every day for your entire life, it's a new activity because you've never been in that moment before. You've never had that particular experience. So that in and of itself can go really far. You don't have to always be doing something new. If you're present in that moment, it's a new moment. So that's like,
I love that. It's like, how the Buddhists say like washing the dishes is the whole point, right? Because like washing the dishes is a huge sensory experience, actually, if you're paying attention to it.
Isn't that right? That's right. And so I would also say to people when they're practicing their mindfulness, and even if they feel like it's an epic fail every day when they're doing their 5 or 10 minutes of mindfulness and they feel like they're failing, they're still learning they're definitely learning something. So it's not like you feel like you're successful at it. It's not that kind of thing.
Right. Don't like do it once and like be like, I should be good now, right? Like it's a
Right.
lifelong practice. Okay, so what do you do
Exactly.
if we say like an adventuresome mismatch in a long-term relationship? So somebody's very fine with like boiled chicken for dinner every single night, and the other person's like, I cannot eat another effing chicken meal to save my life. I need some like
Right.
rigatoni and some dessert, and like a breakfast would be good, right? And those people are like trying to have sex with each other. Like,
Yes.
how do you work with that couple?
Okay, so that is so common. Probably most couples can say, this person wants to do this and this person does not. So, of course, communication and talking it through, I mean, there's no substitute for communication and seeing if you can find some middle ground. And sometimes you can. But I tell you what I look to do, if it's possible, if people are open minded, how we might bring in like VR porn or some new tech that can kind of simulate in some way this behavior and give one person the experience of it while keeping pressure off the other to have to do it. So if they can bring there's so much new tech out there today, different sex toys that mimic different sensations. So I, as a therapist, will look to see if there's anything in that realm that we could use to kind of find a compromise. Sometimes it works and sometimes it doesn't, but there is this whole new array of stuff that can be useful for some couples.
This is so fascinating. And I think a lot of people fear like where to go for good knowledge of like where do you have like resources on your website for like what's up and coming with sex tech, or like where can people go to be like what's reason, because there are people are like, I don't want to go on a website where like
Right.
it's
You
not
know,
good.
right.
Can I volunteer where they should go to get information? Is they should get Marianne's Psychology Today blog.
Perfect.
Well, that's
Okay.
very kind. I love that you said that.
Also the Sex Doctors podcast.
Yes.
And the Sex Doctors podcast. Thank you so much.
Well, my blog is very close to my heart. I appreciate
No, it's a
your,
great place for it.
but I think that like specifics in terms of like sex toys, I don't necessarily cover that. You actually could, I don't know if people know this, you can go on Amazon and find a whole lot of stuff, like a whole
Okay.
lot, just
Yeah.
good old Amazon.com. But in terms of, so there is a website that I like, sexuality resources. I think it's .org. It's run by, it's got a lot of information and they're very gender friendly in terms of showing people or what toys are best for this person with this body trying to achieve this. So they have great information. It's run by a gynecologist and her sex therapist wife. It's just really great. So I think it's sexualityresources.org. If I can get it to you, if you can put it in.
Yeah, that'd be great.
Okay, I'll
Put
do
it in
that
the show
later.
notes for sure. Okay, so what do you say? We're going to gender stereotype a little bit here, but it's for the common good. What do women get wrong about men and sex? I think it's very good for people to know. Because I think it's like, that's just, again, a brain software problem. Is like, we kind of think that everybody thinks like us. And we're like, well, you're in the same house as me. But we don't think the same about this? No, like the big insight is like, if you ask your partner why they like sex or what do they get out of sex, like their why, and then you ask the other partner and you're like, you guys are sleeping together in the same house and you didn't know that answer about each other, and they're like different reasons. That's insightful. No way. Like it could be a more factual, that could be an evidence-based thing. Interesting. And if it does, if they can't, that means there's something wrong with the woman, or she's unlovable, or there's an affair. Like she's stereotyping, but she will internalize it as something very negative about her or the relationship. Not that it's like could be a biologic pump problem. Yes. I learned from lizards. Yeah. I love that. I think it's really good. I mean, it just normalizes everything for everybody of like, hey, we're all human. Like, let's take a deep breath about things. I think one of the things that women don't want from men, and correct me, I'm taking our question and turning it. What I hear over and over again, and I'd like you to expand or correct me. Women do not want to feel, we want to be desired, but we do not want to be objects. We do not want to be repositories for your sexual need. but we want to be desired. Do you know what I'm saying? Like those are two, like it's a Venn diagram that overlaps. We want to be desired by you, but when it turns into you like using us for your sexual need and us not feeling like it's for us, it's a huge turnoff. Yeah, I'm like, we need to talk about that more because I think it's just like subtle shifts in like perception and communication that can fix that problem. Yeah, she's gonna be like, let's do this all the time, please. All the time would be reasonable. Yeah. Because we met at a sex conference about a decade ago. Please do. Yeah. We don't want to be objectified or a repository for semen. Just to be clear. Oh, well, thank you for helping us be specific. Well, and I think the same. I think the same for any gender. It's just as long as it's not all the time. That's. I feel like I'm just here versus I'm with you. I think goes up very. Even I'm like trying to still make it more clear. Like even as simple as like I want you for you. I want you because you turn me on. Like simple clarity sentences, because otherwise she's internalizing like he just needs to get his sexual fix tonight, right? She's internalizing it, whether or not he understands that of like, I want you for you. She's like, hell yeah, I'm at this party. I love it. Yeah. Well, I think that's why sex is such a personal growth platform and like spiritual platform and all the things that it is like, it's not just a certain angle of the pelvis all the time. It's not just a pump. Right? Like, it's not just everybody's like, what's the right lube? And I'm like, it's not always just about what the right lube is. Like, there's a lot to this topic. What's that? Yeah, Crisco, apparently, if you're a preeminent cancer center on the East Coast. But yeah, no, I love it. I mean, this is why, you're going to have a podcast until you want to stop podcasting. And I'm going on year 6 of this. I was like, this is a never ending topic of fascination and people who can communicate it well. I'm excited. It's going to be great. Yeah, I love it. It could be just like this, but more. Yeah. That I love, that's fun too. Yeah. Sometimes I'm like, what am I doing today? Am I the interviewer or the interviewee? I love it. I'm going to share your podcast and I will keep sharing your podcast. Please keep showing up and doing it because you are at the very beginning of your podcast empire. And I'm very, very happy to support you. And thank you for coming on my podcast today. Thank you.